Welcome to the University Transplant Center Liver Transplant Patient Education class. As you know, your doctor has referred you to our program to discuss the option of a liver transplant. Transplantation is a form of treatment, not a cure. As you may have been told before, liver cirrhosis is a chronic condition where normal, healthy liver cells are damaged. The liver cells harden and die, causing the liver to shrink and scar. Indications for a liver transplant are irreversible chronic liver disease with a reduced life expectancy, impaired quality of life, and no medical or surgical alternatives to transplantation. Types of liver disease include alcoholic liver cirrhosis. Prolonged consumption of alcohol such as beer, wine, or liquor can cause irreversible liver damage. Hepatitis, which would include hepatitis A, B, and C. Fatty liver disease, also known as NASH, which stands for non-alcoholic steatohepatitis. This resembles alcoholic liver disease, but occurs in people who drink little to no alcohol. The major feature of NASH is fatty liver, along with inflammation and damage. Another type of liver disease is primary biliary cirrhosis, also known as PBC. This is a chronic autoimmune liver disease marked by destruction of bile ducts resulting in cirrhosis. Primary sclerosing cholangitis, also known as PSC, is a disease that damages and blocks bile ducts inside and outside of the liver. Inflammation of the bile ducts leads to scar formation and narrowing of the bile ducts over time. As the scarring increases, the ducts become blocked, and as a result, bile builds up in the liver and damages the liver cells. Eventually, scar tissue can spread throughout the liver, which causes cirrhosis and further liver failure. Other types of liver disease are autoimmune hepatitis, liver cancer, and cryptogenic cirrhosis. Reasons not to transplant are HIV, cancer outside of the liver, gallbladder cancer, uncontrolled infection in the body, advanced heart and lung disease, and active drinking or substance abuse. This slide demonstrates the healthy liver anatomy. You have the liver, the gallbladder, the stomach, the spleen, and kidneys. This slide shows three types of liver disease: cirrhosis, which is scarring of the liver, fatty liver disease, and a liver tumor, also known as hepatocellular carcinoma. Common symptoms of liver disease are the following: fatigue, ascites, which would be fluid in the belly, swelling in the legs, confusion, also known as encephalopathy, bleeding, itching, and jaundice. For our liver transplant program, we follow the MELD Score. MELD stands for Model for End-Stage Liver Disease. This score is based on the chance a person will die with liver disease within the next 3 months. The numerical scale ranges from 6 to 40. 3 labs needed to calculate the score are total bilirubin, a creatinine level, and a test known as an INR, which stands for International Ratio. This tells us how your blood is clotting. The score is based on the function of your liver and not on the symptoms of your liver disease, not on how sick you feel. The evaluation process. At your initial appointment, you will meet with the surgeon and your transplant nurse coordinator. Blood work will also be drawn at that time, and that blood work will include hepatitis and HIV. Your medical history will be reviewed in detail, and we will discuss your liver transplant options with the surgeon and your nurse coordinator. At that time, a decision will be made whether to evaluate or to not evaluate you for transplant based on your medical history and your blood work. The evaluation process. During the evaluation process, diagnostic testing includes imaging studies such as a CAT scan, chest X-ray, pulmonary function tests, a cardiology workup to include a stress test, an echocardiogram, a social work appointment, a dental appointment, kidney function tests, a hepatology consult, and a nutrition consultation. Once the evaluation is completed, the reports of the evaluation will be reviewed and presented to the Transplant Patient Screening Committee. Participants of this committee include transplant surgeons, hepatologists, nurse coordinators, social workers, dietitians, radiologists, and the procurement team. Transplant evaluation testing results will be reviewed by each individual, and any discussions regarding listing and/or recommendations for additional testing or information are made. This committee meets every 2 weeks. Compliance. The following are important factors when considering your transplant listing status. Alcohol and/or drug use is not allowed while on the transplant list. Your willingness to complete the evaluation in a timely manner, and continue compliance after transplant listing, which would include follow-up clinic appointments in San Antonio, dietary restrictions, and medication. Patient responsibility. The Transplant Committee weighs heavily your commitment toward transplantation. If you miss or cancel appointments repeatedly, this is a sign that you may not be fully committed to a liver transplant. Social support. Having a good social support system, family and/or friends, is necessary for a positive transplant outcome, pre-transplant and post-transplant. Social work services are available throughout the entire transplant process. Also available are information for support groups. Transplant listing. Once the committee has decided to continue with the process of listing a patient for transplant, all the medical records are submitted to your insurance provider for insurance authorization for transplant surgery. Your coordinator will call you to obtain new blood work prior to listing for transplant. Once the patient is listed for a liver transplant, you will be notified by letter, and your referring doctor will receive all the transplant evaluation results and a letter regarding your transplant status. You will be required to attend a pre-transplant education class once you have been listed for a liver transplant. Routine follow-up. Our routine follow-up procedures include blood work, social work updates, routine liver CAT scans or MRIs, random drug and alcohol screens, and clinic appointments with the transplant hepatology team. The transplant team asks that you continue your follow-up appointments for all other medical issues besides liver with your primary care provider. Wellness checks to be included are mammograms, pap smears, colonoscopies, prostate exams, immunizations, and so forth. Wait time. Factors that affect transplant wait times include your blood type and MELD score, availability of organs in the donation service area. Decisions to accept an organ for you are made by your transplant doctors, and extended donor availability. Extended donor criteria. It is a policy of the University Transplant Center to utilize as many organs as possible, with the knowledge that by using extended criteria donors for recipients willing to accept them, we are able to help a greater number of patients. Extended criteria liver donors and risks. Age. A slight decrease in survival with increased donor age. Hepatitis C status. These donors, about 5% of the total population, are used in patients with hepatitis C with the patient's consent. Previous exposure to hepatitis B, which would mean a hepatitis B core antibody positive result, are used in patients with hepatitis B or that have been immunized for hepatitis B. Partial or split liver is a cadaver organ felt to be healthy and suitable to split for an infant and for an adult. Changes in listing status. Insurance changes, noncompliance, health issues, outdated MELD lab, loss of contact with the program, and positive alcohol and/or drug screens can change your listing status to a status 7 or a hold within UNOS until these issues have been resolved. Transplant surgery. The approximate time for liver transplant surgery is 3 to 6 hours. The average hospital stay is 7 to 10 days, which includes 2 to 3 days in the intensive care unit. Hospital care will be overseen by the multidisciplinary transplant team. Upon discharge, care coordination will be transferred to a post-transplant nurse coordinator. Transplant surgery risks. Risks to transplant surgery include bleeding, which may require blood transfusions, infection, such as a wound infection, pneumonia, respiratory complications, organ rejection, especially during the first 3 months after transplant, transmissible disease from the donor organ, blood clots, heart attack, stroke, and death. Discharge coordinators. The transplant discharge coordinator will meet one-on-one with each transplant patient and living donor. Their job is to verbally review patient's transplant manual, teach each patient and family members when to call the transplant team, what signs and symptoms to report, the importance of taking medication properly, and self-care topics that would improve the outcome of the transplant. Discharge care. Frequent clinic follow-up visits in San Antonio are required. This would be up to 3 months post-transplant surgery. Possible rehabilitation services may be needed, lifetime medication regimen, yearly imaging studies, social work availability, and continued education. Patient responsibility. A successful transplant is directly related to you and your ability to take your medications correctly and attend all follow-up clinic appointments after transplant. You must take your medications exactly as the doctor prescribes. Each one of the medicines help keep your new liver healthy. If you stop taking your medications, you will reject your new liver. Post-transplant risks. Rejection, infection, psychosocial, cancer, high blood pressure, kidney problems, reinfection of original disease. Rejection. Rejection may be due to various factors. One of them could include medication noncompliance. If you do not take your medications, you will reject your new liver. A non-functioning liver. Clotted veins, arteries, narrowing or leaking bile ducts, basically bad plumbing of the liver. Infection. Another post-transplant risk is infection. Infections can be related to immunosuppressive medications, hospital-acquired infections, and community-acquired infections. Diabetes. Drug therapy used to prevent graft rejection can also impair insulin secretion or decrease insulin sensitivity to the body. Some patients will become diabetic post-transplant solely on medication therapy. Psychosocial risk factors. Some psychosocial risk factors include financial stressors, depression, altered body image, altered mental status, caregiver burnout, loss of support, guilt, resentment, and disappointment, emotional and psychiatric disturbances. Cancer. Patients are at increased risk for many types of cancer due to immunosuppressive therapy drugs given post-transplant. Therefore, prevention and cancer screenings are extremely important. Colonoscopy, mammograms, especially skin cancer prevention. Kidney problems. Some kidney problems can be affected by the post-transplant medications. Many can be traumatized from the surgery. Increased risk of kidney damage if you have diabetes, high blood pressure, or are malnourished. Best prevention is compliance with medication and close follow-up with the transplant doctors. Reinfection of the original disease. Diseases such as hepatitis B and hepatitis C, autoimmune hepatitis will recur and may lead to recurrent cirrhosis. Such viruses have been shown to be more aggressive after transplant. New livers will be infected and can be compromised. SRTR Data. SRTR stands for Scientific Registry of Transplant Recipients. These are outcomes information of our transplant center. Copies will be provided to you every 6 months by your transplant coordinator. And that brings us to an end of our liver transplant patient education class. Any questions can be addressed to your hepatologist, your surgeon, or your transplant nurse coordinator.